field to support that evaluation, right? So we're evaluating their appearances, their behaviors, some of those symptoms, mental health history, life circumstances, right? All of those things that we can gain in that first realm of seeing that client, which is why that mental status exam can be so important. And we're also focusing on what that primary diagnosis is. Why is that client coming to us, right? What do they need treatment for? And how can I support that? We also can utilize assessments for differential diagnostics, right? So rolling out diagnostics that might look very similar, which is another thing we tend to see in the diagnostic field, is differentiating between conditions that have very similar symptoms. And then we also have comorbidity. So being able to recognize that it might potentially be multiple diagnostics and not just one.
So, case conceptualization. After and we're kind of starting with this, we know diagnosis is so important early on, but we're now moving through. So, after a diagnosis, we analyze and we look to theoretically based explanations of the informations that we're obtaining in a lot of that initial clinical assessment, which is going to vary depending on where you are in practice. Theories are great because it's helping to provide a hypothesis about the cause and the nature of the presenting problem. So you heard Jacqueline in the very beginning. She said, I'm working from a feminist perspective. And so that's driving a lot of the work she's doing. Some of you may be working from different perspectives, and we can talk about that here in a bit. But what is nice about using theories is they provide a framework for developing the most suitable treatment approach. So, thinking outside labels or diagnostic codes, but this is a way that we're seeing how can we offer description of the client's history and how the disorder evolved. So many schools of thought here. Just a question here in green at the bottom of the slide. What theory do you work from? While we're waiting for some thoughts, I work from a cognitive behavioral perspective. So that has many different components. We look at problem lists, core beliefs, precipitants and activating situations, working hypothesis, treatment plans, predicted obstacles in treatment. But those are all things that are part of that initial work and in case conceptualizations. I see in the chat client centered, leaning towards Gestalt and person centered. So that's all going to be family system. That's going to be a really helpful way of looking at your client, looking at a hypothesis about what's going on when our client is presenting to us. And then we also always want to add a cultural consideration. So, what is the cultural background and the role of culture in the manifestation of symptoms and dysfunction? The DSM TR that we're 5 TR that we're working from right now has really great assessments associated with diagnosing and looking at culture for consideration. So the DSM has a cultural formulation interview that might be something that you want to look at for support. And there's other associated assessments like cross symptom assessments, but a lot is provided if you go to the APA website or in the DSM. It makes a lot of references to it as well, which is great. So there's many models, or I should say many versions of how to diagnose, different steps you can take to diagnose. This 8-step model by Hammond 2022 is very simplistic, so I like to show it. Typically, we look at our clients coming in, we're identifying complaints, symptoms, we're making observations, we're looking at cluster related symptoms and observations. So this is really important as Carrie had mentioned before, looking at differentials. So what are we identifying as possible diagnoses, or what's a potential diagnosis or diagnoses? And I think one of the things that we'll probably get to talk about later in this presentation is that it can be challenging to diagnose because some diagnoses are so similar. So this 2 and 3 process is really, really important and can take some time. Along with step 4, locating the potential diagnoses and their criteria via the DSM-5 TR. Step 5, applying relevant diagnostic principles. Then we want to make sure that we are justifying all of the work that we're doing and the decisions that we're doing when we're making that diagnosis. And we're adding that along with any coded diagnosis to a treatment plan or a client note in some form. It's kind of how we're moving here. And so about treatment planning, following assessment and diagnosis, a treatment plan should occur. This treatment plan should be an agreement that is in place with your client. I know working with beginning students, sometimes it's like, oh, I know the perfect treatment. This would be great to do. And it's like, okay, what does our client think about that? What were their goals for therapy? And are those aligned? So just remembering that we have clients that come in and we may see symptoms and we may want to diagnose in another way, but we also want to make sure that we're really listening to our client. And what are your goals? Why are you here? What do you want to focus on? I had a military veteran who I saw in practice, and he came in and he said, well, I've been diagnosed with PTSD, borderline personality disorder. I've also been diagnosed with adjustment disorder and depression and anxiety and this whole list of diagnoses. And I said, wow, like, thank you for sharing that with me. That provides me with important context about just your experience in counseling. But why are you here? What do you want to work on with me in session? And his response was, I want to work on building stronger relationships with my family. He'd been deployed so many times. His kids were tiny and now they're adults. So it didn't really matter to me that he had all of those other things. It mattered to me why he was there and what he wanted to get out of treatment. So important when we're thinking about that balance too of diagnosing and treatment planning and what your clients want. So why is attention to diagnosing, assessment, and treatment important?
So as a lot of you brought up in the chat about that diagnostics or that diagnosis following clients and things like that, that's where ethics come in, right? We, as clinicians, we follow a code of ethics, which follows us through our practices and how we do things. So as clinicians in diagnosing, we have to remember that we don't want to cause harm, right? We want to be supportive of those clients as much as possible. So these are just some ethical codes that we want to be conscious of while we're in that diagnostic process, right? So we want to make sure that the assessments we're utilizing are carefully selected and appropriate, right? So if we're assessing a client, we want to make sure that those assessments are appropriate so that they then can help us justify what that diagnosis is. We also want to identify culture and understand how socioeconomics and culture experiences can be considered when diagnosing someone with a mental health disorder. We also want to make sure that biases and prejudices are taken into account. Dr. Pytel will probably tell you when I came into diagnosing class, I had a bias that we were overdiagnosing everything. That wasn't entirely a bias, I don't know. But you know, that is something that I would have to keep in check while I'm diagnosing, because ultimately my first thought is we're not diagnosing at all, you know. So making sure we're aware of those prejudices and biases can help support that as well. And also reframing from harm. So we want to make sure that when we do find that diagnosis, we are conveying that as supportive as possible to the client, so we are not causing that client any harm moving forward.
So that brings us to some of our initial questions about like, who are you? Why are you here? What are your thoughts about diagnosing? Because diagnosing can be so difficult. And there's a list here that I would say all needs more research to support it. But from what I've been able to see and read, lack of training in identifying mental health problems. So that could be one area. There's one diagnosis class officially, formally in counseling programs. So thinking about that, like we do talk about it in other classes and we try to infuse that, but just the time that it takes to learn about all of the diagnoses. And I think, Christy, you had said it before, you're working in a very specific field. So you're probably with highlights and bookmarks in one section of the DSM, and then it's like, oh, look at all these other ones. I mean, I don't remember how many pages the DSM-5 TR is, but every time they make edits, it seems to get like a bigger and longer book. So just having the time to be able to sit with that book and work through it, understand how it's working, know how diagnoses have changed. Lack of confidence in diagnosing. So that's another one. I think a lot of times it's easy to diagnose one way or another just because it's like, oh, this one feels like a less severe diagnosis. This one feels more comfortable to me. I know what this one is. And there's some symptoms that support that. Exposure to mental health issues despite prevalence rates. So what this means is, again, kind of depending on setting, you can work in places that are more geared towards diagnoses than others. So I'm thinking of working, I guess an example that I have from my past is working in a private outpatient counseling center that was focused on trauma. Like, so high rate of diagnosing PTSD. And so I wondered too if people that had naturally gravitated towards that, like, I mean, yes, trauma is so prevalent these days, but just because we were in an environment where it was geared towards bringing individuals in, if we were diagnosing PTSD at higher rates than we should have. Maybe it was something else. So maybe it was just grief and loss related to an event that someone experienced, and it wasn't really a formal PTSD diagnosis, but we were making it fit because of the environment that we were in. And I think sometimes that's true too for settings that work a lot with children these days and ADHD. So other difficulties, inadequate reimbursement or managed care, and insurance requirements. This goes back to what Denise said earlier of like, policies and procedures are you see your client one time and you have to give them a diagnosis if they want to use insurance and can continue on. So that doesn't give you a whole lot of time and autonomy to direct how you want to do diagnosis. Individuals may only have a few symptoms of a disorder or might have symptoms from multiple conditions, and diagnoses from different professionals will widely vary. So again, that kind of comes back to like setting and what people have been most exposed to. But I always told my class, like, if it doesn't fit, it doesn't fit, right? Like there may be some symptoms, but it'll also be interesting too, because just, you know, depending on how you're looking at the case or how long you've known your client, you might be like picking up on things that are leading you one way, but another mental health provider in the field is like really latching on to something else, and that's taking them another way. And we'll see that in some of our practice later today, but that does make diagnosing different if you've got two mental health people looking at the same case in the same room and two different diagnoses result. And then just inconsistent screening tools. There's formal tools out there, there's informal tools that people use. So depending on what you're using, sometimes that just makes the diagnosing process more difficult. So I am going to turn it over to Brandon, who is going to introduce us to the evolving case study and how that relates to our purposes of being here today.
Thank you, Dr. Feitel. So yeah, we're doing the evolving case study today. This is something that we've been working on for a while, largely prompted by us having gone through a diagnostics class and seeing how this diagnostic process and all the different diagnoses are taught these days, and how there's so many of them and it's so hard to conceptualize them in intermittent, broken up, completely separated case studies. And we'll talk about that a little bit more right here. Instead of having many separated case studies, this case study is continuous. And the reason for this is it encourages us to think and learn more about the diagnostic process and how it relates to lifespan, and how a diagnosis can change over time and symptoms and the person themselves can change over time. Just like working with clients in general, we only receive information little by little, and then our conclusions change in tandem with that. Diagnoses change because we learn more and more over time, and that's how it goes in real life as opposed to these singular case studies. Let's look at one right now.
Before we get there, Brandon, I just want a show of hands or in the chat, how many of you learned how to diagnose based on just like single case studies? So you read a case study and then they said, what's the diagnosis? A lot of us. And so you'll see how this evolving case study is different because yes, you are working with a case, but it's intended and you can use it if you're a site supervisor or you're an educator or you're a student, you can use it in different ways. But really the hope is in a class to, as students are learning more and more throughout the semester, you would have them continue to work with this case, but after a period of time, you would give them a little bit more information. So you're seeing someone over time versus, oh, here they are. Tell us what this is. So we're curious to see your feedback about how this works once we show you what our case is.
Here we go. So, birth of a client. This is going to be stage one of the entire vignette. Our client is a 6-year-old African-American male named John Doe. John is referred to mental health services due to frequent calls home from school regarding his inability to follow directions, such as reading quietly and remaining seated. Client's mother states that client is typically well behaved at home, except for occasional instances in which he plays too rough with the family pets, leading to the pets becoming injured. Mom wants to be involved in every step of counseling. And so, as we read through this, there are some questions that we'd like you to keep in mind. And if you have answers right away, please feel free to put them in the chat or speak up. What symptoms are you noticing right off the bat here? With those symptoms, can you come to a diagnosis or any differentials? Any assessment tools you'd like to use to rule out other things? Do you notice any ethical issues in this situation? And if so, how would you navigate these ethics?
So let's start with the symptoms. What are some important symptoms that you're seeing? Again, we want to think about potentially diagnosing John. Amanda, injury to animals.
Some impulse control issues.
Some parent-child relationship issues potentially. So those are great. What are some ethical issues? If you're viewing this from the lens of as a counselor, Brandon was like, what are some ethical issues? And I want to know too. Animal abuse, mom wanting to know everything, threat of harm to pets. Perception of mom versus school and age. Yep. Now, thinking about both of those things, what would you diagnose John with? If this is what you knew, and it's like you need to provide a diagnosis now.
I would probably blanket it with an adjustment disorder. Like, what's the adjustment in the environment versus going with ADHD? Because I feel like ADHD is so overplayed right now. Like, and there's such a difference between the two environments until there was an assessment done. And I forget the name of the one where you send everything to like the three different teachers in the school, and then the one from the home, and then you sit with the kid and you do that one. But that's the one I'd want to do.
Yeah, so it's tough right now because this is all the information that we have. All right, well, let's look at a little more information. I see Amanda too agreeing, wanting some more screening and assessment to occur.
Okay, so we're moving on with John. John is currently 16. He's attending a predominantly Caucasian private school in his area. And as we remember, John is African American. He was referred to mental health services after the school guidance counselor observed John struggling with paying attention in class. His thoughts appeared to be racing, and an incident where he was found involved in sexual activities with another student, which was a minor, who was 12 years old in the school bathroom. John's mother has also reported concerns due to John struggling with sleep and getting involved in bad crowds, as mom described. His mom wants to be very involved in the treatment process. So as we look at this one, what are some of the symptoms that we are seeing now in John?
There's definitely a cultural difference.
Cultural difference? Yeah, very good. Inappropriate sexual activity with a minor, sexual abuse history, cultural issues. Mom is a helicopter parent. Any other symptoms we're seeing? Private school, unsure what type, yep. Attention deficit again, okay. Okay, so we got some of that racing thoughts, struggle paying attention, those kind of things.
I'm wondering if there's some trauma history there.
Might be a good place to maybe do a trauma assessment. So as we're looking at some of this, what are some of the ethical issues that we potentially might see?
Well, the age difference between John and the child that's involved, that right there is a mandated reporter issue.
Mhm.
I also say like getting a good read on what John's symptoms are without mom present seems like that's going to be a huge ethical struggle.
Yes, very much so. Very good. And with the information that we have, yes, we have confidentiality 16. Because at that point we don't have to talk to mom, right?
I think it's 14 in PA.
Yes, it is 14. 13, right? No, 14. 14. Yeah. So as we're looking at these symptoms, what are we thinking diagnostic wise now? We have a little bit more information than before.
I'm
So
going into the trauma history. I'm
Trauma
going into the trauma.
So how about we get a little bit more information? And what we did with this case in particular is we did a 2-week update for you guys. So I think maybe once we get some of that information, we can kind of move through this.
Thank you, Carrie. So as Carrie said, this is a 2-week update. So 2 weeks later, John's mother shares that he has been irritable just about every day. And he's also had an increase of energy over the past few weeks. His mother also shares that he had gotten into a fight at school and then started missing school days. And then when you speak with John, you learn that the fight that he physically initiated happened immediately after one of his classmates made a racist remark towards him. And John's drug test came back negative and his medical assessments were all regular. So I'd like you to take a moment to process this information. And just like we have been doing, please share any symptoms that you notice. And again, you're welcome to do that in the chat or using your mic. Bullying leading to a fight, increase of energy, increased agitation, increased energy and physical aggression, irritability. Yeah. Okay, and now this time around, I'd like you to also think about any ethical concerns that might pop up for you. Christy is saying still with the adjustment disorder wheelhouse, but also still like the trauma history. Okay, thank you for sharing. Culture, racism, discrimination, cultural sensitivity. Yes. Great. Okay, and now I'm going to ask about diagnosis at this point. What are we thinking now in terms of diagnosis? Christy's wondering about generational trauma. Emily, adjustment disorder mixed with disturbance of emotions and conduct. Parent-child relational problem, affected by parental relationship distress, child psychological abuse. Andrea says opposition, perhaps bipolar or a mood disorder, at least as a differential. Great, thank you for sharing. Anybody else have any other thoughts or ideas? All right, we have one more segment for you here.
So we're moving into adulthood now. Okay, so we have John. He was referred for mental health evaluation based on going to the emergency room with thoughts of harming himself. John reported recently getting divorced from his wife 6 months prior and being unable to see his children. John reported moving back home to his mother's home, where his mother attempts to be involved in all aspects of his life, and mother attempted to attend evaluation appointment with him. John reported struggles with sleep and being unable to get himself out of bed. John reported planning to harm himself most days, but the day that he went to the hospital was the first plan that he had. So as we look at John in his adulthood life now, what kind of symptoms are we seeing and ethical issues potentially? Depression, not getting out of bed. Very good. Anxiety and sleep disturbances, suicidal ideations. Depressive symptoms, that mom, yes. Mom is a reoccurring factor as we start to see, right? So as we're looking at some of these, do any of you have a diagnosis for John in this adult life? And we are going to tell you these diagnoses a little bit later, but. Depression. Anyone else have any ideas? It's hard without the screening. You are correct. You are correct. Still wondering about bipolar. Schizoaffective, maybe. That would be something good to screen about too. Unspecified trauma and stressor related. And trauma is not something we really looked at in here, so that's a good insight as well. I think we've harmed you guys enough that potentially maybe you guys want to see what we're working with now. So let's kind of move on and see what the diagnostics were moving through his lifespan.
Okay, thank you, Carrie. So here's for the big reveal. In childhood, there were strong indications of ADHD, like many of you had said, and a light indication of conduct disorder. And I believe a few of you also put that in the chat. And moving into the first part of the adolescent years, there was a potential for bipolar 1 diagnosis. And I believe at least one of you also put that in the chat. And part 2 of the adolescent years, at this point in time, John now meets the criteria for bipolar 1. And there are maybe some hints of conduct disorder. However, due to the context, we don't give this diagnosis. Instead, we would put a Z code Z60.5 for target of adverse discrimination or persecution. And then the last part 3, adulthood, the primary diagnosis is major depressive disorder. And some of you also put that in the chat, so great job. And the secondary diagnosis is bipolar 1. So I think a lot of you had really, really great thoughts and ideas, especially like looking into trauma, and a lot of you really had the right idea.
What do we think about this? What do we think about the last slide, which gave us the diagnoses as we were seeing him throughout his life?
I think that it makes sense, but I also, like, one of the things I remember from diagnosis class was that some of us would have different ideas of what the diagnosis was, but if we could like show our work and like what we were doing, then that was fine. And it feels like a Rorschach to me. Like, I still think that it could be other things. And of course, this is a fictional person. Like, I still want to know what the dynamics were between that mother and that kid. And was he sexually abused by her as a kid? And like, I just feel like there's so much. Like, could there be PTSD involved? Like, you know, and then it's just like having this diagnosis. And I don't have the answer, but like, is this helpful? Like, what will knowing this do for this person? And some of these diagnoses, especially the bipolar one, is something that really can follow a person around, you know, and even like, sometimes it's helpful for somebody to be like, oh, you know, this is something that I'm living with, and how can I manage this? And it's helpful to have this diagnosis. And then for other people, it could really be a source of stigma. So I think it's so gray, this whole thing. And when I'm looking at these diagnoses, they make sense to me.
Thank you, Denise.
I just have so many questions. Like, I always hate case studies because I have so many questions that don't ever get answered. But like in my head, like I was going towards like, is she like a Munchausen by proxy? What do the medical records indicate? Like, what's the longevity of trauma, and how does that play into the potential of like the depressive symptoms? And then like when he was thinking about harming himself, is it because he is frustrated? Is it because he hears command hallucinations of how bad of a person he is because of the trauma of his mom? Like, I mean, I get the concept of case studies, but there's so many more like complex factors, like Denise was saying, that could potentially play into these diagnoses. So to say like, yes, I totally like buy into those diagnoses is kind of hard because you don't have like, I don't know, there's a lot more out there that could potentially lead to diagnosis.
Mm-hmm.
And I was going to say, I think that's a really important part of why we wanted to bring this to you guys, is because as students, we get one case study with like one paragraph, right? And to diagnose someone like that, or to teach someone to diagnose like that, is really difficult, right? And as you guys are talking and creating these questions about what if this or what if that, that was a common conversation in diagnostic class, right? So we wanted to bring this idea of like, if we're teaching students how to diagnose with just that one paragraph and not allowing them to really look at how those symptoms can change and how those diagnostics can change, right? All those questions and those assessments and things like that, you know, we want to be able to teach those students to be able to do that moving forward, which is why we thought this was just so important to present for you guys.
It's also a really good way when we think about the shift from the DSM-5 to the DSM-5 TR. If there were more published cases like this, what a great exercise to get us into the DSM-5 TR and understand how it's organized, right? Like it does go developmentally. It considers lifespan. As you get older, right, then you can be diagnosed with different things, and symptomology and things like that look so different. So thinking of your roles, if you're a supervisor or an educator, like finding ways to put this together as like an interactive training or something that you do with colleagues or yourself, just to better understand the new versions that come out, and how gathering more information could potentially change that is kind of a cool way of looking at potentially using these. We're not saying that ours is perfect, but it's a really good example of being able to pick whatever time points you want to be able to play and show different things. I know in my class, like, these are disorders that we're looking at the screen that are a little more, students are more familiar with them in general, even coming into the diagnosis class. But what about a case that is exposing students to something that you would never think of? I'm going to put Brandon on the spot. Brandon, what was a diagnosis that we read about that you were like, huh, I've never heard of this? And you just kind of in a roundabout way stumbled upon it in our diagnosis class because there wasn't a ton of time to focus on it.
Really anything like an elimination disorder, really does not cross my mind ever. So yeah.
It's a good one. I know our class had a lot of good conversation about that one.
It also makes me want to be an advocate and be like going to insurance companies and be like, you force our hand in a situation in order for us to get paid that's not beneficial to the person that we serve in any way, shape, or form. And then also to take into consideration how social media and like I've had clients come to me and say, I took a survey on Pinterest, I have anxiety. And I'm like, what are you talking about? Like, stop. Like, it's insane how all these different mediums affect this, but like it is a big deal because these things do come. We get clients who walk in who've had multiple inpatient hospital stays and come in with a myriad of diagnoses, and you start talking to them and you already realize like 3 or 4 of them aren't even real like good diagnoses, and then trying to then educate the client, get them to realize that they don't have necessarily this laundry list is challenging. That's all. It makes me want to do advocacy work, I guess.
Amanda, I was actually gonna say something about how many clients come in, adults and adolescents, because I deal with both of them, and they say, well, when I'm doing the assessment or the intake paperwork and we're going over things, and I say, okay, have you had any mental health history? And they say, yeah, I've had this diagnosis and this diagnosis and this diagnosis when I was in the hospital, but I don't feel like that fits me. And I say, well, it may not anymore. When you were in the hospital, you were in a crisis situation, and your situation was very different than it might be now, because that was also 3 years ago or 4 years ago. So have you talked to anybody since then? Have you, gone through any other counseling since then? Or, and they're like, no. And I'm like, okay, so maybe you want to get those services going too. We can help you with that, because diagnoses can change. They're like, what? Diagnoses can change? I'm like, yeah, absolutely. Things change all the time.
And
So
let's
they're
not
they're
forget
not
that
even aware that their diagnoses can change, which is amazing
and
to
I think
educate
bringing up
them.
that the PCPs are also another player in this game too, because you got primary care doctors giving diagnoses out so people can get meds because psychiatry is so backed up, and they don't have the training in mental health that other people do, and they're like, but my doctor said, and like when a doctor says something, it becomes like the gold standard, right? So there's that piece of it too, and it's a challenge.
I love this discussion of the complexities. Sorry, Dr. Patel. I think that's really what we're trying to show with this evolving case study. We're not necessarily trying to make it simpler. We're more trying to illustrate to students the complexities around these situations.
Yeah, and Amanda, to your point, I had a great conversation with my practicum class just on Tuesday about just being prepared for the fact that clients are going to come in and they're already going to say, this is my diagnosis. And a lot of it is self-diagnosing because of something that they saw on social media, or like you said, they took an assessment, or they just did all this research and decided that they had something. And so it takes a lot of time then to work backwards in some way of being like, okay, I want to hear you because there's probably some validity in what you're saying, but like also like let's start at the beginning. And like, why is it so important for you, for me to know that you're narcissistic? Like, no one's ever going to admit to that one. But like, if someone came in and was like, I have narcissistic personality disorder, like, it's really hard to be like, okay, wait a second. Where did that diagnosis come from? Was it like you're saying, was it from a mental health professional? Was it from a medical provider? And then, okay, that's kind of part one. How are you feeling about that diagnosis, right? There's just so much to explore, but it can be so difficult when clients come in and they're like, I have this and I want to fix this, right? Because our role is to be supportive, and it just is more difficult in that way. But I do want to be mindful of time. I greatly appreciate all of you being here today. Our contact information is on this slide. Feel free to reach out to any one of us to consult or to collaborate. We would love to hear from you. And if there's anything else, we can take a few more comments, but we also want to make sure that you have time to make it to your next session. So